So we have a wonderful chair for this session. Let me introduce to you Sana de Courcelles, who is the director of the Global Coalition for Social Justice at the ILO. But she's not just this. I learned that she is a health activist and she is passionate about health equity, about many of the issues that we've already discussed today and that we will touch on during this session, about the people at the heart of the system. So we are delighted to have Sana with us today. We will be together for an hour and a quarter discussing this topic. And after hearing from Sana, we will move on to a short interview with our colleague Madi Diagne, who is joining us virtually from Cameroon and who will discuss the situation of health workers in Chad. And then we will have Jana Topalovic, who is the labor economist at the Directorate for Employment and Labor and Social Affairs at the OECD, also joining us virtually. And following that, we will have Michelle McIsaac, who is sitting with us on the podium. Michelle is the economist at the WHO's Health Workforce Department. And after Michelle, we shall be hearing from Banani Dekka, who is joining us from India virtually, from Public Services International, PSI, who will also be talking about community health workers. We hope to have time for a brief question and answer session before a final round of comments and considerations and final thoughts from all our speakers and closing remarks from Sana. So that's our plan. Let's get started with Sana. Over to you.
Thank you. Thank you so much, Constanza, and good morning, good afternoon, good evening to everyone. I'm excited and really glad to be here, and I'm really happy that we have this session among us. This interagency workshop is really dear to me because I belong to the two houses. I'm a former WHO staff as well, and I was behind the Commission on Health, Employment and Economic Growth. I was the chief of staff of the ADG who framed all of this, and I know how we knocked on the door of the ILO and the OECD to bring together the institutions, and now we are all here together. A lot of things have been done. A lot of things needs to be done again and continuously. But thank you for being here, and I'm glad to provide, to share with you some key messages today. So very clearly and concisely, we all know that achieving universal health coverage depends on the availability of strong, well-supported, well-trained and motivated health and care workforce. It was the case 10 years ago. We already faced huge challenges, but after COVID-19, after all the evolution since then, we know that it is absolutely critical, not only for healthcare systems and to deliver on universal health coverage, but just to keep peaceful and sustainable societies. So informal work, which is the topic of the day, of course, persists and raises a lot of concerns and of particular concerns. We all know that health sector informality tends to be larger than comparable other sectors, like education, and when there is an over-reliance on community health work, informal and volunteer work in families and communities considered as a hidden subsidy to health systems and society that should be recognized and compensated. There is a strong need for regulating, accrediting, and integrating the informal workforce in varying skills level into the formally employed health workforce, ensuring obviously decent jobs, but also social protection, rights at work, and equal pay for work for all. And we know that we have a predominantly female workforce faces systemic gender inequities, with women often in lower skilled, lower paid roles, and facing greater barriers to full-time employment, leadership, and career progression than men. Gender transformative policy and action is required to address the global health and care worker shortage and gender-related workplace challenges, for instance, to address occupational segregation and gender pay gaps, and to establish workplace measures to better accommodate family responsibilities, mostly borne by women. We all believe that investments in social protection, occupational safety and health, and decent work for health and care workers are key for health and to health and to society, for health to all and to societies. Through the joint ILO OECD WHO Working for Health program, we are here and we will continue to provide critical assistance to countries, social partners, and key stakeholders for the development of strategies for scaling up investments in their health workforces based on improved health, labor market data, multi-stakeholders involvement, and social dialogue. I'm really glad to, again, hear from our different panelists, their perspectives, and also to answer questions from the audience. Over to you, Constanza.
Dear Sana, thank you very much for your words and for mentioning the Working for Health program as well. Another hashtag for people there if you want to post on social media. Of course, there's hashtag USP and hashtag UHC Day. So happy UHC Day to everybody, by the way, if you've only just joined us. Now we will turn to our colleague, Madi Diagne, who is the technical specialist for decent work in the decent work support team for Central Africa at the ILO. Madi, bonjour.
Bonjour, Constanza.
Bonjour, bonjour. We will switch to French. So if you're listening to us online, click on the icon and pick whatever language you want, which is not French if you don't speak French. And if you're in the room, we'll give you a few seconds to adjust as well. And I will conduct a very short fireside interview, as they call it these days, with our colleague Madi, who will tell us more about the situation of health and care workers in Tchad. Bonjour Madi. Alors, on passe à le français. Ma première question, et on aura environ 8-10 minutes pour cette interview, mais je voulais vous demander, parce que les Tchad figurent sur la liste des mesures de soutien et des sauvegardes du personnel de santé de l'OMS pour le 2023, ce qui indique des défis importants en matière de personnel de santé. Pourriez-vous détailler la situation du personnel de santé et des soins au Tchad, en particulier en ce qui concerne les conditions de travail et de l'informalité?
Merci beaucoup, Constanza, et bonjour à tous les collègues présents à cette journée et à tous les participants. Je dois juste rappeler que je travaille au Tchad pour le compte du BIT dans le cadre du programme Working for Health que nous partageons avec l'OMS et l'OCDE pour renforcer le personnel de santé, améliorer les conditions de travail et fidéliser ce personnel. Et c'est dans ce cadre-là que j'ai pu avoir cette connaissance de ce secteur de la santé au Tchad que je présenterai dans ces conditions de travail comme un secteur qui a une situation assez mitigée. Parce que d'une part, nous avons un secteur qui fait partie des secteurs les plus attractifs de l'administration publique. Pourquoi? Parce que c'est un des secteurs où la rémunération est l'une des plus avantageuses du secteur public. Et ça, nous le devons à une négociation collective dynamique entre les partenaires sociaux et l'État qui a permis aux salariés de ce secteur d'obtenir des primes et autres avantages qui améliorent considérablement les revenus du personnel. Mais d'un autre côté, quand on apprécie la situation et conditions de travail du personnel de santé du point de vue de la sécurité et de la santé au travail, nous nous rendons compte que les performances sont faibles, voire nulles. En effet, il est difficile dans les structures sanitaires, même celles qui font partie des plus importantes, c'est-à-dire les grands hôpitaux, les centres hospitaliers universitaires et tout, de voir des comités d'hygiène et de sécurité qui fonctionnent ou des programmes efficaces qui ont des résultats en matière de réduction des taux d'accidents du travail ou de maladies professionnelles, mais où aussi on peut trouver même des actions concrètes, même si c'est des actions isolées de prévention des risques professionnels. Alors qu'aujourd'hui, nous sommes dans une situation où la sécurité et la santé au travail est devenue un droit fondamental depuis 2022, où c'est devenu le cinquième principe et droit fondamental au travail. Nous nous rendons compte que pour le moment, ce n'est pas une priorité centrale des autorités au Tchad, que ce soit les autorités au niveau du ministère, mais aussi les autorités au niveau même des structures sanitaires. Et à titre d'exemple, aujourd'hui, la question des troubles musculosquelettiques est une préoccupation majeure pour les agents de santé parce que tous ceux qui, de par leur travail, ont des activités consistant à soulever, pousser ou tirer des charges lourdes, y compris les patients, souffrent de troubles musculosquelettiques. À ce jour, ils arrivent à se faire réorienter, réaffecter à d'autres postes où ils n'auront pas besoin de solliciter leur force physique, mais il est clair que cette situation ne peut pas perdurer parce qu'il arrivera un moment où ces réaffectations ne seront plus possibles. De l'autre côté, il y a cet aspect qui est que on assiste dans des cas où il n'y a pas de déclaration du personnel. Soit c'est d'un personnel qui est recruté sans contrat, soit il y a des contrats, mais ces contrats ne sont pas conformes aux prescriptions légales. Et même les salaires ne sont pas conformes aux salaires conventionnels ou aux salaires légaux. Et aussi, il y a cette non-déclaration, voire cette sous-déclaration des maladies professionnelles et des accidents du travail. Et ces deux aspects combinés créent une informalité dans le secteur de la santé, une informalité des emplois, alors qu'on est pourtant dans un secteur éminemment formel, puisque les structures sanitaires, dans leur grande majorité, dépendent de l'administration publique, dépendent de l'État. Donc, voilà rapidement la description que je peux donner de la
Merci.
situation du personnel au Tchad.
Vous avez parlé de plusieurs défis. Comment est-ce que le Tchad a relevé ces défis et est-ce que vous pouvez nous dire quel rôle les dialogues sociaux, la sécurité, la santé au travail et l'extension de la protection sociale en matière de santé jouent-ils dans l'amélioration de conditions de travailleurs de la santé, y compris ceux qui occupent des emplois informels? Et je vous invite à être bref, s'il vous plaît.
D'accord. Alors, pour relever ce défi, le Tchad bénéficie, comme vous le savez, du programme Working for Health, qui a privilégié une approche multisectorielle. Cela veut dire qu'aujourd'hui, les principaux acteurs de l'amélioration des conditions de travail du personnel de santé au Tchad, qui ne sont pas seulement le ministère de la Santé, mais les autres ministères, par exemple le ministère du Travail, le ministère de la Fonction publique, le ministère de l'Enseignement supérieur, mais aussi les partenaires sociaux se sont retrouvés autour d'un comité multisectoriel pour le renforcement du personnel de santé. Et c'est un cadre de dialogue important sur lequel le Tchad s'appuie aujourd'hui pour mettre en œuvre des stratégies efficaces. À cela, il faut ajouter que le programme Working for Health promeut la mise en œuvre du HealthWise, qui est un outil développé par le BIT et l'OMS, pour améliorer la situation du travail dans ce secteur-là. Enfin, sur la question du dialogue social, il faut noter qu'on a voulu également impliquer les inspecteurs du travail pour ne pas laisser seulement les acteurs en interne dérouler le processus. Et ces inspecteurs du travail jouent un rôle important dans l'impulsion, mais aussi dans l'encadrement du dialogue social et des processus qui doivent se dérouler au sein des structures sanitaires.
Merci, Madi. Ma prochaine question est à propos des leçons d'autres pays et comment ils peuvent, comment vous pouvez tirer de l'utilisation par le Tchad du dialogue social pour établir un consensus entre les parties prenantes et créer un personnel de santé plus équitable et plus durable.
Oui, la principale leçon qu'il faut tirer ici pour les autres pays, c'est vraiment en matière de dialogue social, surtout la mise en place de ce comité multisectoriel, qui est vraiment une bonne pratique que nous conseillons à tous les pays qui s'intéressent à l'amélioration des conditions de travail du secteur de la santé et du personnel de santé. Parce que c'est un cadre de dialogue et de collaboration qui facilite vraiment et grandement l'élaboration et la mise en œuvre des stratégies consensuelles. Les autres pays peuvent aussi s'inspirer du Tchad qui a impliqué l'inspection du travail comme acteur externe des structures sanitaires, mais dont le rôle est crucial pour impulser et faciliter le dialogue social au sein des structures sanitaires. Voilà donc les deux grandes leçons, je pense, que le Tchad peut partager avec les autres pays.
Merci, très clair, Madi. Et ma dernière question, alors, c'est à propos des efforts du Tchad et quelles sont les prochaines étapes ou les priorités, disons, pour maintenir les progrès dans l'amélioration des conditions de travail et la lutte contre l'informalité et le renforcement du personnel de santé.
Oui, en termes de prochaines étapes, je pense que déjà, le Tchad peut bâtir quelque chose sur les acquis actuels, mais il devra surtout faire son auto-évaluation concernant le comité multisectoriel pour apprécier déjà son efficacité. Est-ce que les stratégies qui ont été décidées à ce niveau sont suffisamment efficaces, mais surtout son inclusivité. C'est-à-dire, est-ce que toutes les parties prenantes intéressées dans ce processus sont bien présentes dans le comité et arrivent à contribuer efficacement. Le deuxième point, c'est la consolidation et l'élargissement du pool de formateurs. Parce que le Tchad a mis en place un pool de formateurs sur la santé, sécurité et sur le dialogue social pour assurer la qualité des formations, mais aussi la durabilité de cette approche qui est en train d'être développée là-bas. Et de ce point de vue, l'inclusion des inspecteurs du travail nouvellement formés pourrait constituer une opportunité. Et enfin, le Tchad devra mettre à l'échelle ce programme pour couvrir tout le territoire national. Cela demandera un plus grand engagement de l'État, un engagement financier plus important. Et cette mise à l'échelle pourrait s'appuyer notamment sur une stratégie mixte de parrainage d'une structure sanitaire par une autre plus importante et qui a déjà une expérience dans le domaine du programme HealthWise, mais aussi d'inclusion directe des autres structures par le comité multisectoriel en utilisant le pool de formateurs existants en fonction des spécificités techniques de la structure sanitaire, mais aussi de sa situation géographique. Donc, je pense qu'avec cette approche combinée aussi, on pourra étendre la couverture de ce programme sur tout le territoire national.
Madi, je vous remercie beaucoup. Vous nous avez donné des pistes et une feuille de route très claire pour le Tchad et aussi des réflexions sur les sons très importants. Merci beaucoup pour votre...
Merci.
Merci. I will switch to English again. So we are now moving on to our next speaker, who is Jana Topalovic. I introduced her earlier. She's the labor economist from the Directorate for Employment and Labor and Social Affairs at the OECD. So Jana, we are very pleased to have you with us today. And Jana will tell us more about the role of skills and flexible pathways in tackling informality and advancing decent work for health and care workers. Jana, I believe that you will be sharing your screen. Is that correct?
That is correct. And let's hope that all technology is on our side today. So if you could tell me if you see the presentation.
Perfect. Yes.
Great. Then we can get started. Thank you so much for the introduction and for the invitation to speak today. I'm so sorry I couldn't be there in person, but I am ready to discuss with you from here in Paris. And like you said, my name is Jana Topalovic, and I work at the Skills and Future Readiness Division here at ELS. And what I work more specifically on is skills and adult learning. And today I will be presenting our newest work on flexible pathways into healthcare professions, which is a collaborative initiative between the OECD, the ILO, and the WHO under the Working for Health program. And let me just try and get this to agree. Okay, so before we sort of get into the policy aspects of this paper, you might wonder what we actually mean by flexible pathways. And I'm quite sure that everyone who is connected today and in the room knows that skill gaps and shortages in healthcare sectors are costly, and they can contribute to significant unmet medical care needs. And in many countries, there are not enough healthcare workers. And in many countries, there are also healthcare workers who don't necessarily have the skills to carry out the tasks and responsibilities that are demanded by the healthcare system. And so flexible pathways is a concept that is closely related to adult learning, which is the education and training that is done after your initial education. So the profile of an adult learner would be someone who has already graduated initial education, already has some years of work experience, and is undertaking further training to advance their careers. And flexibility is really about looking at these training programs and tailoring them to the specific needs and constraints of adult learners, while at the same time meeting the needs of the labor market. And having worked on flexibility quite a bit here at the adult learning team, we see that this is being more and more applied to general adult learning systems, but the conditions in the healthcare sector are slightly different. So the healthcare sector is unique in the sense that many of the occupations are highly regulated with very strict education requirements, while other occupations might not be as well described and have as many regulations attached to them. So what we wanted to do is look at how we can use flexibility in adult learning for the healthcare sector, which is traditionally a somewhat inflexible field of education. And so our first finding was that the flexibility principle is really well suited for training related to low and medium skill occupations. So these are the type of occupations that are often at the support level role, and they serve as a really good entry point into the healthcare workforce for many adults. And so increasing the accessibility and tailoring of training programs for these occupations would make it easier for adults to qualify for these positions, but also increase the professionalization of occupations such as care workers, where there might not be as many training requirements or occupational descriptions. And so we identified that flexibility is well suited for two types of adults. It's those who are looking to transition into the healthcare sector after already starting their career somewhere else, but it's also for the workers who are already in the sector, who have the skill, who have the experience, but don't necessarily have the formal qualification. And I think this is the group of people that we were interested in discussing today, because these are often informal workers, workers in the care sector, or people who are hired as generalist workers within the healthcare sector. And so we looked at different countries across the OECD to identify best practices and flexibility for these groups of workers. And what we find is that there's three types of policy initiatives that are very relevant for adult learners. And first is flexible training. So flexible training includes things such as modular learning, work-based learning, and online learning programs that can be used for these entry-level healthcare occupations. And this type of policy tool is particularly useful for occupations that require short to medium length training, but also for occupations that don't necessarily require training yet, but where training is very useful in order to be able to formalize a working contract or progress within the career. And work-based and online learning can lower barriers to participation, such as time constraint and financial constraints. While in addition to these benefits, modular training programs allow individuals to build their own learning pathways for the job that they're interested in. And one of the best practices we found here, it comes from Denmark, where they have implemented a modular system at the vocational education and training level. And here, a learner can participate in smaller courses, which stack up to a module. And once they've completed these smaller courses that are part of a module, they can get certificates, which they can use both in the labor market and for further education. And this allows a worker to increase the visibility of their skills step by step, and therefore also, and this is also recognized by the employer and by the labor market. And then the second policy tool is recognition of prior learning, which is a process by which a candidate will have their skills and experience formally assessed and certified as an education training credential. And this is particularly useful for informal workers who have the experience and skills, but don't necessarily have the certificates to back that up. And a really good example here comes from New Zealand through the Career Force program, where the Career Force program helps both employers and workers to carry out on-the-job assessments to certify the skills of and tasks that the workers are already doing at their job. And these workers are often uncertified or generalist workers in the healthcare sector, which after completing the recognition of prior learning, have access to better working contracts, and they can progress in their careers. And then the third policy tool is career guidance, which is something that is very important in connecting workers with other services and will play a huge role in enabling transitions into and within the healthcare sector. This is also an important tool in encouraging underrepresented groups in undertaking employment in the healthcare sector. And for instance, there's a program in Norway, which is called Men in Health, which encourages and supports unemployed men to undertake training and work placement for jobs in care occupations, which are mostly female dominated. And this is also considered one of the most successful programs for the recruitment of men into the care sector, and largely because of the extensive guidance and support that these candidates receive. And so those are some of the key findings. And one final thing that I think is really relevant for the discussion today is that one thing that would support flexible training and career pathways is really mapping the skills needs, the skills use of entry-level and middle-level occupations, and matching those to the training opportunities and opportunities for career progression. Because many of the jobs that we will be discussing today have a high level of informality, or they might be formal, but without necessarily clear career prospects. And so a mapping of the pathways would support the professionalization of such occupations and support workers in improving their working conditions. And Austria and the UK are good examples of these type of initiatives. And in the UK, there's two initiatives. One is done by Skills for Health, and one is done by Skills for Care, which are two industry bodies, where they map out the career pathways within the healthcare and within the care sectors, starting from an entry-level position and with an increased level up to the highest level you could do within that occupation, where they detail what kind of skills and tasks and responsibility you have at each level, and mapping those to training opportunities across the country, which is a really good information tool for both workers and employers who want to support their workers. And so this is just a very quick introduction to some of the stuff that we cover in our paper, which will be published next year. And I would like to thank you for your attention.
Jana, thank you very much. Incredibly interesting presentation. I think you've touched on some of the issues that Sana had put on the table, so I'm sure that she will be keen to comment. I will give her the floor back after Michelle's presentation. But thank you so much for really showing us the good work that is happening with regard to flexible learning pathways, recognition of prior learning, recognition of qualifications, career guidance. Very interesting points also about men entering the sector, unemployed men. So very, very interesting topics that you have touched on. So thank you again for your contribution. Now we will turn to Michelle, who is sitting on the panel with us, and we will be sharing the screen for Michelle. So Michelle will be talking about effective policy options to address informality, equity, and access in the health and care sector, looking specifically at the role of interagency collaboration. Michelle, you have the floor.
Yes, thank you. Thank you very much for having me. Thank you for inviting us to do this presentation. I think as Sana noted at the beginning of the seminar today, it's been a long pathway to get us to a point where we're working collaboratively with interagencies to really address this issue from a multi-sectoral perspective. I think about 10 years ago, prior to the high-level commission, this was sort of thought of as a pipe dream. If we could get this, if we could get this. And I mean, I think what's really interesting, and you heard this in chat, and there's many examples across the world, we're actually at a point where we're working effectively in countries in a multi-sectoral way, bringing in the different ministers to have conversations. Finance minister is a big one who's been in the rooms with us. Labor, we have gender sometimes in the rooms with us. I was giving an example to a colleague on the way over about foreign affairs being in the room when we're talking about the migration of health workers and really getting that operationalization there and in place and working in a way that's effectively driving change in measurably way as well. So just wanted to say that this is a milestone really for us to be here and be able to discuss some of these outcomes. So the first slide that I have here is just one that I wanted to put up to really kind of set the context and to start us off with a very wide definition of the word work. So for this kind of wide definition, we need to encompass both the paid work and the unpaid work that uphold our health and our well-being. And when we do this, we can see globally that 67% of those who are in the paid health and social work sector are women. But we can also see that 76% of the unpaid care, so even more proportion of the unpaid work, is done by women. And this is important for us to note that there's this interplay, or what we might call as economists a substitution, between the paid work and the unpaid work that we see across economies. And this plays out differently across different regions. It plays out differently across different socioeconomic settings. It plays out differently depending on where countries are on their path to universal health coverage, right? Which is the day that we're celebrating today. So this is really important to be thinking about the interplay between strong health systems, what this means for the world of work, and then ultimately what this means for women's work opportunities. When there's a substitution where there's a lot of unpaid care work, it's likely that a lot of that is being done by women, which is preventing them from entering the paid labor market. Next slide. So to elucidate this point, we can think about work on sort of a spectrum, where we see many forms of unpaid work occurring that occur notably within families or households. So this is sort of the far left side here for unpaid care work. But we can also see this playing out in terms of unpaid community health volunteers, which is a growing area of concern globally, where we have many health workers who are in volunteer roles who are not in the paid health and care work space, or not being counted in sort of labor force surveys where we're looking at paid workers. Then we also have other forms of unpaid health and care activities. Some of these are unpaid civil service work that we see, and then trainee work, which actually encompasses quite a bit of work within certain health systems, is often unpaid. And then we have this componentry of health and care work that's for pay and for profit, which is the paid labor market that we study quite well, where some of this work would be formal work and some of this work would be informal. So some of this work that's paid is still in an informal economy. Next slide, please. So what do we know about this proportion of informal work? So what we know is that across the world, particularly in LMICs, there's a significant proportion of work that's happening in the informal space. In the health and care sector, it appears to be slightly lower than the overall economy overall, but it's really different by context and by country. And I wanted to give one example of a country we studied in depth. I worked a few years ago with a colleague here, Rosalia Vázquez Alvarez, on a gender pay gap study of the health and care sector. And in this sector, we did a spotlight on Mexico. And what we found when we looked at the data for informal is that overall in that quarter of that year, which was 2019, 46% of all wage employees were working in informal economy in Mexico. The health and care sector had a much lower proportion at 20%. But if you think about that, that's still 2 out of 10 workers or 1 out of 5 workers who's still working in an informal paid workspace. And the notable difference that we found here was that 22% of those who were working in informal roles were women versus 17% of men. So women were more likely in Mexico at that period to be holding informal jobs. And then when you really look at it, and the purpose of this particular paper, that informality is actually a key factor behind wage inequality. Next slide, please. So why does this matter? It matters because insecure contractual arrangements, non-standard forms of employment, these can expose workers to higher levels of discrimination, poor working environments, violence. Workers who are working in the informal economy are also more susceptible to health, safety, and economic risks on the workforce side. On the health side, there are also many concerns around how we regulate informal work, both in the paid and unpaid space. Next slide. So here, oh yeah, I updated this slide. So we don't have all of the updates here, but so here, so some of the elements, and I actually put universal health coverage as one of the elements here for policy levers. So if we think about making sure that all the workers are having universal health coverage and having access to health coverage is very important. Decent work is obviously an important element for us to be looking at. Other measures such as the ILO Convention 190, which looks at violence and harassment in workplaces, where we know that health and care workers actually face a stronger risk of violence and harassment in the workplace than most other sectors, and then addressing all of the various forms of non-standard and informal employment. And when we talk about the sector, we're talking about health and social work. And in this sector, we have a growing issue in terms of long-term care sector and the workers that are working in those spaces of really the care having more and more informal and non-standard employment contracts, and many of those workers being migrants. So this is a growing concern for us. Next slide. So the role of collaboration, this is a slide that I took from a guideline that we did at WHO around getting health workers into rural and remote areas. And I didn't change a word in here, but put it up to show how important it is to be thinking about the role of stakeholder engagement and collaboration, and why the Working for Health program and other programs that are really bringing in sectors is really important. So when you're thinking about the choices that health workers are making and the locations that they're working, they're thinking across many aspects, right? And bringing in the national authorities across all of these different sectors becomes very important. So education is a very important element, and we just heard that from the OECD. How are we thinking about that? The program that they had just talked about with the OECD is also a program that's important from a gender equality perspective, right? When you have flexibility in working arrangements and pathways that are more flexible, this can be important for advancement, particularly of, say, community health workers. We have the social sector, which in some economies is not with the health sector, but is a separate ministry. It's important to be bringing those together. Labor, obviously, we've had many conversations around labor and finance. Health tends to be an undervalued and underfunded sector, and then gender and many other sectors. And then on top of this kind of sectoral level work, we also need to be thinking about how we're engaging with other actors such as civil society, the communities in which these health workers are serving, unions, and many other that I've listed here. Next slide. So I just wanted to also then end with a discussion about the Working for Health program, or a little loophole onto the Working for Health program, which is a program that came to birth essentially after the High-Level Commission on Health, Employment, and Economic Growth, and brings together in countries the ministries and the other stakeholders who are really relevant to driving policy change. And you can find out more information by the QR code that's there. Thank you.
Thank you, Michelle, for a very clear presentation, which has really helped to unpack not only the evidence, but also the trends, the policy responses, and the need for collaboration, not only at the interagency level, but also, as you very clearly showed, at the local level, looking at the range of stakeholders that ought to be part of the conversation. So building on what our colleague Madi was also saying earlier. Now, before we move on to our next and final speaker, Banani, who's joining us from India, I know that Sana is really itching to get in, because she is very passionate about the issue, and we would love to hear just a few comments. Now, let me tell you that after Sana's very brief intervention, and after Banani's presentation, we will then open the floor for questions. So if you do have questions, make sure to type those in the Q&A chat if you're online, or just get ready to raise your hand if you're in the room. Over to you, Sana.
Thank you so much. Thank you to all panelists, and I will be very quick, but just few elements. One is we've heard about several countries. I've heard about Norway, Chad, New Zealand. So just to reiterate the fact that health for all is a truly universal challenge that we have to tackle. And we know that sometimes our institutions are focusing, and the technical assistance should definitely focus on the developing world. But if we do not address globally this issue as a universal challenge, we will fail. I've heard the word migration at some point. I will come back in the concluding remark on this specific element that was included in this high-level commission. I think we should definitely make sure that not only we have this cross-cutting discussion and perspective when it comes to working for health issues, but also a truly universal challenge to tackle all together. Second, I really appreciated the presentation, the different presentations, but this flexible pathways study, I would be really keen to look at the report when it will be published. It is very relevant also because we already face this huge gap, and the fact that we need health workers everywhere. So I would be keen to hear maybe in the next round of intervention if you already encompass in this flexible pathway the way to facilitate potentially task shifting to address the current needs that we face already, and how to use it as a concrete pathway to formalize workers and improve their working conditions. You mentioned this improve working conditions, but how to, at some point help or facilitate the formalization of these workers. And I wanted also to say a week before the official opening of the WHO Academy, the WHO has decided to put like one of the flagship program of the WHO will be now a WHO Academy, exactly to address this point, to make sure that we have a health workforce that is first recognized, second motivated and well-trained, and third, regularly also feeded to make sure that we have an up-to-date network of hubs, of local hubs, but also of training programs that are available everywhere. So I really commend the WHO for having initiated this program, and the opening celebration will be held next week. And also this working for health discussion and how to provide access to basic needs, which is a concept that was initiated within the ILO 50 years ago. But it is a way to say that we want to address a social justice issue. We would like to provide dignified life to all, and working for health is one of the key pathways to do so. I just wanted to finally share something that I never shared publicly, is that for this high-level commission, initially, it was working for health commission only, so health employment. But, working with the ILO and the WHO is really critical, and we already have plenty of collaboration and common and joint work. And we suggested at some point in the discussion to add and economic growth, health, employment, and economic growth. Why? Because working for health employment, it provides a triple dividend, as you mentioned, on women career and empowerment, on access to health and basic needs, but also to provide peaceful societies and to have sustainable development, a truly sustainable development. We need a very strong investment on health employment. So let's keep in mind that these three components are highly supportive and you know, with this potential a way to mutually reinforce our own mandates, and we need to act together and to move the rest of the communities because we need other stakeholders to help on this particular agenda. Over to you, Constanza.
Sana, thank you so much for your initial considerations. You will have more time at the end to share more thoughts, but let us move on to the next speaker who is joining us from India. We have Banani Dekka, who is the Gender Equality Officer at Public Services International, also known as PSI. Banani, welcome.
Hi, Costanza. I hope you can hear me clearly.
Can hear you indeed, Banani. So Banani will talk about another very important component or element, a backbone of primary healthcare. So talking about including community health workers in social protection. And she will bring lessons from Nepal and India. So Banani, you have the floor, and I believe that we will be sharing the slides for you.
Yes.
So let us get started. We'll, there we go. Excellent. You have the floor, Banani.
Thank you. Good evening, good afternoon to everybody. Very glad to be a part of this important discussion on World Health Coverage Day. I'm from work in Public Services International. It's a global union federation, and I bring the workers' perspective into this discussion. It's been a very interesting discussion to be a part of. And I'll dive right into it. Can I have the next slide, please? Yeah, Public Services International, with our affiliate community health workers unions in Asia and Africa, have been fighting for the rights of the community health workers as public sector workers entitled to a wage and decent work. Well, I'll not get into the specificities of the work that they perform. This is 100% women workforce, and that work as an essential bridge between the public healthcare system and the communities, often outnumbering the physicians, nurses, and midwives combined in the public healthcare system. Can I have the next slide, please? Community health workers have filled a very significant and major gap caused by the underfunding public healthcare systems, particularly in rural and marginalized communities, which have a scant formal healthcare infrastructure, supporting significant improvements in public health, including especially maternal and child mortality rates in South Asia. But a very significant part of this workforce is that they work as volunteers. This characterization of community health workers as community volunteers or activists, as majorly known in countries like India and Nepal, actually reflects the historical and continued devaluation of women's work, which is a widespread trend in low-income countries. It also signals the government's unwillingness to invest in a regular cadre of human resources for public health in rural areas and also urban areas, as it would have long-term fiscal implications. Thus, the economic aspect of it, which we mostly avoid, is also very important to highlight, because this particular workforce have been subsidizing the government for decades, and it has been at their own expense. Can I have the next slide, please? Next slide. So while we see and because of these particular reasons, and as we have tried to give an overview of the community health workers, particularly in South Asia, and the comparison of the number of community health workers and the tasks that they perform, and especially if you notice at the remuneration, it is as low as $500 annually. If that has been the reason that we see at Public Services International organizing and unionizing community health workers as the first priority to ensure they have a collective voice at different levels of even policymaking, discussions, lobbying, social dialogue. I'll go a little back to 2020, at the height of the COVID-19 pandemic. Community health workers with PSI launched a campaign, Community Health Work is Work, to address the numerous threats and violations that were being endured by community health workers during the campaign, during the COVID time period. We have been able to sustain this campaign because of the numerous wins that we have seen through across this time period. The key demands of the campaign has been formal recognition of community health workers as workers and not volunteers, decent pay and regular remuneration, access to social protection, including healthcare, maternity benefits, and pensions, provision of adequate training, equipment, and infrastructure, support, since mostly they have very little training that is provided, as you can see in the table. While this is also very important to highlight that the experience that these workforce gather during their field work is not, it mostly goes unrecognized and undervalued. And lastly, protection against occupational safety, health, and risks. Can I go to the next slide, please? Next, please. Yeah, so in 2022, actually, when ILO had the General Survey for Convention 149, community health workers across Asia and Africa made a submission in ILO on behalf of the community health workers unions. And we were actually successful in getting the Committee of Experts on Application of Conventions had actually put up in the report that community health workers are undoubtedly covered by the community health fundamental rights and principles at work. This has been a major achievement in terms of the workers' voice getting reflected in an international report by an international organization and actually getting recognition. Similarly, our work has also reflected in getting a worker's voice in the ILC care document, outcome care document. So as I have mentioned that the collective voice of representation is very important for the community health workers. Coming to the wins and achievements of the unions, of the workers' unions, in giving the perspective of South Asia, how the workers have been able to win these rights have been amazing, because these workers they work on honorariums without any basic workers' rights. And I would also like to highlight the flexibility part here. This has been also a contentious thing, because when the governments also bring the flexibility part in the policies and say that it's just 4 hours of work that these women will be doing, and that is how they are brought out of their homes in terms of volunteers. But that's where also the exploitation begins. So at the policy level, we'll also have to see how we would like to tackle this, because we are dealing with 100% workforce. Yes, the flexibility gives them opportunities to come out of the homes and work, but how do we tackle the exploitation part of it? Back coming to the wins, PSI affiliated unions in Pakistan have been leading this fight for a decade and have won the recognition as community health workers, as public sector workers, while the fight for the polio workers is going on as they are not regularized as workers. Significantly, in 2018, although the Pakistan lady health workers are recognized as public sector workers, but they were not allowed to register as a union. So, which was a long fight for the unions, and they won the right to register as a union in 2018, which has opened doors for unions to be formed in other provinces all over Pakistan. Well, a major win for us has been that in November of 2024, 20,000, can I go to the next slide, please? 20,000, next, please. Women health, community health workers from all 4 provinces of Pakistan have united through PSI to form the Pakistan's first community health workers union, which is the Pakistan Community Health Workers Federation, and they are pushing for the rights and recognition of this workforce. Can I go to the next slide, please? Next, please. Yeah, so the Nepal unions have been successful in registering the community health workers under Social Security in multiple municipalities. This registration of community health workers in the Social Security system marks a very significant milestone in the ongoing struggle for the workers' rights and social justice in Nepal. Well, when we talk about India, also in 2024, the community health workers have been able to obtain health insurance coverage through the government, and one very significant fight that one of our affiliate unions have led has been a 21-day strike for maternity benefits, for maternity leave. Actually, the community health workers themselves do not get maternity leave. So this 21 days long strike was led by the community health workers without calling off work. So it was so they would continue the work and as well as the strike, and made the government come at the negotiation table with them, and they have won maternity benefits in that union. So these are few of the wins of the community health workers, which underscore the power of collective mobilization and advocacy in effective positive change, and serves as a beacon of hope for workers' movements worldwide. Well, I will not go into the recommendations, and perhaps we can have a discussion later too. But since we have been talking about interagency collaboration, so it's very important that we talk about international cooperation, and we would urge organizations like WHO and ILO to come together where we can actually talk about standard setting mechanism for developing and adopting specific ILO guidelines, or a dedicated instrument on decent work for community health workers, addressing their unique challenges and needs. Well, it also needs fostering international cooperation, because as Sarah had said, that it is a global coalition of global justice. So we need to take concrete initiatives and targets for achieving decent work for the community health workers. Thank you.
Thank you so much, Banani, for bringing these very apt, and it's very dark in here. Very cozy atmosphere here. Thank you so much, Lou. So thank you for bringing these very effective examples from South Asia of how organizing workers, in particular community health workers, can indeed help to convey their voices and their needs and improve their legal recognition, their formalization, and their working conditions as well, of course, as well as providing them greater access to social protection, which is their right, as is everybody else's. So thank you very much. Now we have come to the question and answers element of our session. I don't see any questions online. Oh, yes, there is a question. Let's have a, excellent. We have a question from Senegal, from Dr. Serigne Diouf. His question is, I presume to everybody, but mostly to you, Banani, I guess. It's about health insurance for community health workers. Do community health workers have health insurance? And if yes, if so, which health insurance scheme are they affiliated with? Now, are there any questions in the room as well to add to Mr. Diouf's question? There is a question there at the back. If you could turn on your microphone and maybe just tell us your name before asking your question. Thank you.
Yeah, thank you. Do you want me to go now?
Please go ahead.
So I'm Asia Odugli-Kolev. I'm from WHO. I work in the Integrated Health Services Department. Do you want to ask my question now? Yeah. Okay. So my brain sort of working on overdrive since this morning, actually listening to all of the excellent presentations, and I was struck by the last presenter and the enormous amount of work that's taken to get community health workers to be formally recognised as being part of the public health system, and my question is around the fundamental notions of social care, in that, and I speak as a former nurse, that within the current functioning of national healthcare systems, social care is seen as being desirable. It's not part and parcel of a holistic approach to the kind of services that need to be provided to populations. So the formal sector itself operates from a place of disconnect. So what is it that can be done to address the fundamental issue where social care is not very well understood? It's not seen as being within the mandate of healthcare. We are still, the system itself is heavily focused on treating diseases and symptoms. Prevention and promotion is not, there's not enough investment. So there's something fundamentally flawed with the current system itself. And so I think, how can we take all of these learnings and start to look at some of the systems levels changes that are required? And some of this morning's presentations also talked about building systems. We already have systems in place. So how are we changing those systems so that they operate in socially aware and socially accountable ways? Thank you.
Thank you very much for your question. There's one question or contribution here at the front from Shara Razavi.
Yeah, thank you so much for this really interesting panel. And there was a lot of rich material here. I just have a question. Maybe it's to Michelle, but also anybody else. I mean, this idea that we talk about of unpaid and paid care being substitutes. I wonder how I think maybe we need to interrogate that a bit more, because even as more paid forms of care have become available, the evidence from time use surveys shows that the time allocated to doing unpaid care is not reducing. It's not going down. So I think the idea of them being complements, and we know, for old age care, for other forms of care, often families kind of complement and co-produce care with the professional care providers. So I think we may need to just, I mean, I've used that notion myself. I'm not, so I think it's just a question to all of us. I think that may need a little bit more scrutiny and questioning, this idea of the two being substitutes. Thank you.
Thank you very much for 3 questions. Thus, we have the health insurance for community health workers, and then a question on social care, and I think reflections really also on, how do we make that count? How can it be better understood? And do we need system level changes from our colleague from WHO, Asia, I believe? And Shara, yes, paid, unpaid care, time poverty. Is that improving, not improving? So maybe we can start with the most straightforward question, I guess. Banani, I guess that was aimed at you about the access of community health workers to health insurance. Banani, if you want to take that, and maybe if you have any other thoughts on the other questions, but then I would like to also bring in our other speakers, and Madi also, if you also want to come in to respond to the questions. We have about 3-4 minutes.
Thank you for the question. Thank you, Costanza. So in terms of the health insurance for community health workers. In India and in Nepal, the community health workers, since they work as volunteers, so no, they are not covered under any labor laws. So say they do not get any coverage. They do not get pensions once there is no retirement age. There is no social protection of any kind. Well, their access to healthcare is also not free. What this year it has been declared is that they will be included under the universal health coverage that we have for by the government, that we have for everybody. That the workers will be included in that coverage, but well, we'll have to see how far it pans out, because insurance is, again, like when it brings in a lot of laws, you'll have to be in India, you'll have to be hospitalized. It has to be a particular government hospital that you'll have to go to access healthcare. So it is, again, yes, it is not precaution. Although this workforce mostly provide primary healthcare and work towards precautionary healthcare, but they do not have access to free healthcare. So our demand has been access to free healthcare and also access to universal health coverage.
Thank you, Vanessa.
I've been clear, yeah.
Thank you very much. Who would like to take the question on social care, and then we have the paid, unpaid care? Why not? Michelle, have a go.
Okay, I'll try and do both. So I think the question on social care is a really, really foundational and fundamental question. It's one that's coming up a lot in the UN system, right? So we have a lot of discussion around, care systems, how these interface with health systems. And the truth is that in many countries, it's operated differently. So in some countries, we have health and social care, say NHS, right, in the UK, and this operates together. And in some countries, you have a health and you have a social, and they don't operate together. They might not even communicate together. And this really impedes us when we're trying to do integrated health and care, and as we're operationalizing towards that. So Korea is an example where you have two very separate ones. And so I think at WHO, what we've been trying to do in the Health Workforce Department is really pushing an agenda of integrated health and social care, and what that looks like in countries might be slightly different, right? So where we already have communication, this is going to be a little bit easier for us to operationalize, and where we have these in completely separate budget lines, right? So, I mean, the way that I talk about it with some of our colleagues in finance, when I get really confused because all of this is happening around social care, and they say, follow the money, Michelle, follow the money. And where the budget line is, then that's okay. Then who cares what we're calling a system? Because the system is ostensibly the money that's going to a certain place. So I think it's confusing when we talk about systems and we don't have a clear definition of systems. It's a concern that I have with the increasing, agenda that's going towards sort of the rights of the social care and how we're actually going to think about this, because I've always thought the same. I mean, being a Canadian, I've always thought the same, that the health system encompasses social care. And this is one thing. And so when we talk about the social care system, that's confusing to me. But when you go and work in certain countries, it is that, right? It's over here. It's not part of our core. We're not talking anything about this. And in other places that. So I think there's a long way to go to get harmony across how we do this. And I think it's still a big pathway for us to look at, and something that WHO needs to be doing more of. On the question around paid and unpaid and the substitution, I agree that there's a lot of maybe complementarity is a word that can be used too. But there was a study done by Felicia Null, who you may know, who's an economist at Miami. And what Felicia did, so this was a study that they did after the Lancet Commission on Women in Health in 2016. And what they did is they tried to use time use survey to actually tease out the health-specific unpaid care work, because one of the problems that we have is when we're using time use survey, we put all of this care together, and a lot of the care is child care. A lot of the care, it doesn't fit within the remit of ministries of health, and it's something I get a lot when I go into countries. Well, care is child care, right? And I was like, no, care covers many aspects. But what Felicia and colleagues did is they teased out the care that was health specific, including things like getting water, right, as being a health-specific activity. So procuring clean drinking water and other being health-specific activities. And then they looked at this unpaid health-specific care work, and then the size of the health system, right? So how big the health system was. And what they started to see was that there was a relationship between having a really comprehensive health system and the amount of unpaid health and care work. And part of this, of course, is going to be about economic development, right? And many other co-founders that are looking at these things. But there is some evidence to suggest that if many of the needs are being met by formal health systems, that they aren't being taken up in communities. But it doesn't really matter, right? Because at the end of the day, it's not really about the substitution, it's about the choice, right? And so it doesn't really matter if it's a substitute or it's not a substitute. It's that if you're doing unpaid health-specific care work, that you're doing that because you choose to be doing unpaid health-specific care work, not because that health-specific work is not available to you in your public health system, right? So I think maybe it will always be a choice in certain cultures to take on this specific kind of care work. But the fact of the matter that we're focused on is mainly, is it a choice or is it an obligation? Because if it's not, if you don't do it, no one else can.
Thank you very much, Michelle. I think we'll have to leave it at that, just in the interest of time. But we did want to end with a whirlwind tour of just final statements. And always in the interest of time, I have a challenge for our speakers. So I will give you 1 minute each maximum to just give us some parting words, and mostly focusing on what you think is missing and focus on what's next as well. So let's make this as forward-looking as possible. Okay, so I will be timing you. And you will have 1 minute each maximum. Perhaps maybe, Rana, we can start with you and move around our panelists. There you go, our brave soul to take on the challenge.
Great, thank you. It's been really interesting listening to the other presentations and also some of the interventions that have been made. And if this one thing that I would leave this meeting with is that what we see here at the OECD is that there seems to be trends indicating a diversification of the type of roles that are existing on the support level, the entry level. So there's different types of workers, there's different types of occupations and different types of skill needs. And with this diversification, it really opens up for formalization if the correct training policies are attached, because the worst that could happen is that we have a lot of new support level occupations and we just assume that people will show up from thin air to fill these roles. And that's just not the way that it works. So what we would like to see is more training and support policies at this level to formalize this type of work. I hope that's within the minute.
That's amazing. 50 and your call to action. Brilliant. Set the stage for the other speakers to follow. No pressure, of course. So let us move to Madi. And of course, Madi, vous pouvez parler en français. Madi, j'espère que vous êtes encore avec nous. Perhaps not. Let's move to Banani then. Banani, you have the stage. 1 minute for your call to action and what's next.
Yeah, thanks, Costanza. So final takeaway is that we need more interagency collaboration, and where the highlight is that healthcare is for people and not for profit. Recognizing the human right to care, governments should prioritize the health over profit by increasing public health systems budget, investing in universal public health systems, social protection, universal health coverage, promoting more transparent hiring processes for community health workers, recognizing and regularizing them, and by establishing a fair tax system to mitigate the inequalities that we are facing. Thank you.
Even better. 35 seconds and a list, a whole shopping list there from Banani. So thank you very, very much, Banani. I think we have a clear path ahead. So let's turn to Michelle. The challenge is on.
The bar is set. So, and I won't make it because I wanted to do one plug, which is that WHO does have a community health worker guideline that I think is not being uptake. So I think we need to actually be encouraging governments to read and adopt many of those. The one thing, I mean, I think it's a whole of society, whole of government kind of approach, right? And then working at ways like Working for Health that we can actualize this, and then making sure that there's funding mechanisms from that. I think what we see is that it is this question of where the money is going. And if the money is going to one agency, then it's hard to kind of share. And so if we have mechanisms that actually make this feasible, that's what we really need.
There we go. Yeah. I think everyone is playing really nicely. Excellent. So we have come to the end of our session, and it's time to give the floor back to Sana de Courcelles, who has the arduous task of bringing it all together in just a few minutes. Over to you, Sana.
Thank you. Thank you so much for you, Constanza. I really appreciated the way you moderated the session, but also the speakers and the panelists. It was really, really interesting. 4 buzzwords and 1 call. Look at the general title of this, looking at the general title of this workshop today, we have universal health coverage. No universal health coverage without health workforce. So this is, I remember that with the WHO, within the WHO, we had these building blocks, you remember, on the social systems. I know that now it somehow disappeared, but like...
Still there.
It's still there, okay. But at the end of the day, we need people. We need to address people needs through people that are highly motivated, recognized, and in a good working condition. So no universal health coverage without health workforce. Second, and universal social protection. We need universal social protection. And we all know that this is not happening everywhere. I really liked your presentation about paid and unpaid. I had exactly the same question as you, Shahra. So thank you for raising it, and thank you for your great answer. It's a matter of choice. I really like it. But let's build an agenda, a strong agenda all together on access to social protection. Third, we have this health, equity, and well-being. This is decent work in social justice agenda. We have already the collaboration going. We have the Global Coalition for Social Justice, Let's Act. And a 4th element that I wanted to add is the importance of social dialogue. And thank you so much for raising all these things, Banani, on health workers, community health workers, but more generally, health workers count. The voice of health workers counts. We cannot do anything without their voices. And I would like also to emphasis on the importance of one handbook that was also issued by the WHO, a handbook on social participation for universal health coverage. It includes social dialogue dimension, but not only. We need a triangle to make it happen when it comes to health services. We need health workers, we need health systems with all its components, but we also need people that are also driving safely within the health systems and taking care of their own health. And the call would be, you remember during the COVID-19, Dr. Redros was saying always test, test, test. Let me quote a little bit and change the word, invest, invest, invest. Invest nationally. This is the first step. We need governments that are highly involved and committed to invest. And to do so, they need fiscal space. To do so, we need prioritization on the social dimension of sustainable development. And we need to do the case for health employment to bring and to deliver the sustainable development goals. So to do so, we need 3 champions, the OECD, the ILO, and the WHO. We need you to be the driving force, and not only to act alone, but also to bring together so many other stakeholders, including PSI. Thank you again, Banani, sorry, but also other stakeholders, including at regional level. The African Union has shifted we need to work with them. The European Union now has a global health strategy, and they have included health workforce as one of the key priority in their programmation. Let's work with them under your leadership. Invest in youth, invest in women, invest in social justice for a healthy society. Thank you so much.
What better way to close a session? Thank you so much to our speakers here and our speakers virtually. Thank you for sharing your knowledge and expertise and examples, very concrete examples of what is happening in this space, about the conversations we're having and that are yet to be had in this conversation. So it's a moving target and we will monitor it very closely. So we are now moving on to a coffee break before we then have our final session, which is going to be exploring universal social protection for health and well-being in the context of multidimensional crises. So stay with us. If you're online, you are welcome to go and make yourself a hot drink if you want, or take a comfort break, but we shall be back at 3:45 or 15:45 Geneva time.